the beginning because on my other stimulator, I have it at about 1 or 2. So I have it there. And then this wheel starts at 0 and then it clicks on. And I just start, so it goes 2, 4, 6, 8. So I start at around 2 or a little under. It's better to have them not feel it at all than to alarm the patient with a lot of unexpected stimulation out of the blue. So when I use this, like I said, it's normally on either sensitive points or if the patient's in a position that I don't really want them resting in the entire duration of their treatment. So we talked a little bit about the subscapularis treatment last time around heart 1. We'll follow up on that today. But the patient has to have their arm extended and abducted, and I just it's not often comfortable to lay this way when the patient has shoulder pain for the entire duration of the treatment. So in that case, I make my rounds around the points and I hold it there. You can see when you get it going, there's this little light at the top, just like other electrical stimulators. The little light will flash at the frequency. Oh, where is it? There it is. So it's not on right now, but here's the little light. So that little green light is going to go boop, 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 boop at whatever speed you have this going. So I look at the light and I usually do it for 4 to 8 pulses per point. So I go boop, 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 and then I move it, doot, 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 and then I'll move it back and forth. And I'll just do that for a few minutes. And then sometimes that's it. So let's say I'm needling the jaw, which would apply to facial acupuncture. Sometimes I'll use serins or really, really thin needles. And depending on the angle of the patient, sometimes the leads on the unattended e-stim units are a little heavy for those points. So, or for those needles. So I'll just use the point stimulator at the beginning and at the end of the treatment. If, from an ortho perspective, if you're needling the jaw and it's really, really achy just at rest, they might not need a lot of stimulation anyway. So, I'll do a few minutes at the beginning of the treatment and sometimes at the end if I have time. And then the other way I use it is if somebody is really apprehensive about electrical stimulation or they don't know what it feels like and they want to kind of get a sample, you can use that just to kind of show them what it feels like if you have time. And then the other way you can use it is to check to see if you have the needle in the place you want it, right? So in the quads, for example, or if you're really targeting specific muscles, if you don't get the twitch response without electrical stimulation, let's say you're doing a motor point, it sometimes requires some stimulation to get the motor point to vesiculate, right? So if you're not sure and you're not getting a twitch response, you can essentially, wind this around certain points and you can see which muscles are moving. So that's one way to use it diagnostically. You can tell what tissue you're in and you can see the points that really have optimal twitch response, and you can use that sort of diagnostically to connect your unattended e-stim device if you have a Pantheon or something else. So I hope that is helpful. And if anyone has any other questions about that, feel free to jump in. The other question that came up is about labs and imaging studies. So just to be clear, in the state of California, We are primary healthcare professionals. So that gives us a license to order labs and imaging studies, actually. We can order x-rays. We can order MRIs. We can order CT scans if you know what you're doing there. However, one, our training isn't always, especially for the more advanced imaging studies, it doesn't always support that level of detail. But that said, like I feel comfortable ordering probably an x-ray or blood work, but when it comes to an MRI or something like that, there are details about it, contrast, no contrast. There are a lot of things that we don't really get into. That said, from a practical point of view, it is often better for the patient if you refer them back to their primary healthcare provider for the imaging or the labs from a insurance coverage perspective, primarily. The likelihood of an insurance company covering our orders, labs is maybe a little bit better, but we're going to have to work so much harder to prove medical necessity. And patients have to go through the ringer, even with their primary care, sometimes in order to get a referral for an MRI. So for us to just skip that step and do it is great. However, they're very expensive. And so, again, from an insurance perspective, it's better to route them through their primary care because they're often all connected. They're within the same buildings and networks, and they can send those orders over electronically and get pre-approval a lot easier than we can. But lab work is slightly easier. Quest Diagnostics is the lab that does most of that around here. There are kits you can order for your patients to do different tests at home, but Quest has stacks of lab orders, and you could just fill them out and give them to the patient. There's carbon copies, and they can just walk in and schedule that. So if they're paying out of pocket anyway, that might be a non-issue. So I hope that's also helpful. So if anyone doesn't want to add to that or jump in with another question, we're going to move on. And our plan today is to, we're going to just run through the elbow, easy peasy. So it's going to get easier. I know that the spine is overwhelming, the shoulder's overwhelming. It took a while to get through those. And I do want to follow up on that last bit of the shoulder just because we kind of rushed through it at the end. But I want to start actually with the elbow. Because where we end is sort of where we'll begin to just recap the shoulder. And just a quick word about our timeline here. So next week, we're going to do wrist and hand. That's the 2nd of July. And then the week after, the 9th, is when I plan to do the midterm. So the midterm will be, it will take you a lot less than 3 hours to do. I'm not going to give you 3 hours worth of questions. I typically allow, or I encourage you to try to take your test at a pace of 1.5 minutes per question because that's what the board exams allow. And it's just it's good to get used to that pace. But because this isn't a review class, I'm not going to be super strict about that. I don't know exactly how many questions it'll be yet, but it'll be a minimum of 50. So it'll probably take just a little over an hour or so to do it. So I'm thinking if you like, and we can take a vote on this, but if you want to, before the midterm, we can do a little review. And for those of you who want to join, you can. And for those of you who want to study on your own before the midterm, you can do that for an hour. But if we meet from 1:30 to 2:30 and do sort of a quick little review, and then you can jump into your test for the rest of class time. So that's what I'm thinking. If anyone's opposed to that, let me know. Okay. All right. So great. Thank you. Okay. So we're going to jump into the elbow, but I'm going to start on the last slide actually. And so I think it's helpful as we run through to know what you're going to be responsible for knowing. So when you hear that information, you can tune your antennas to it, right? So let's try this week and see. And some of this may be a little overwhelming right now, and some of it might not be for those of you who are already familiar with a lot of this. But in the way of anatomy for the elbow, I just want you to know which muscles are responsible for flexion, extension, pronation, and supination of the elbow and forearm. You don't have to know the detail about where they insert, originate, all that stuff, but I want you to know which muscles flex the elbow, extend the elbow, pronate, and supinate the forearm. And then which joints of the elbow move in those planes as well. So we'll talk about all that. The most common thing you'll see in the way of elbow pain by far is first lateral epicondylitis, and probably second would be medial. So I want you to really know and be able to distinguish between the tests for medial versus lateral epicondylitis. There's one condition that you might see that looks pretty alarming sometimes if you haven't seen it in real life. Olecranon bursitis, it can be pretty dramatic looking, and we'll talk about that, but there are some red flags to keep an eye on. So anytime there's a safety issue or concern, pay attention to that. And then I want you to be able to distinguish between valgus and varus stress. And we're going to talk about that in the physical exam section, and that will also help you. This used to confuse me a lot when I was first learning it, but when we get to the knee, it's going to be helpful. So this will be kind of the first round of valgus and varus. And then differential, again, medial and lateral epicondylitis. Know everything about those two. And then how to DDX is short for differential diagnosis. Know how to differentiate between ulnar neuritis, thoracic outlet syndrome, and a C8 cervical nerve impingement, because they can all kind of present with numbness and tingling down a similar pathway. So thoracic outlet, you'd have to look back in your shoulder lecture, and C8 would be in the spine. But just connect those dots. And then like everything else, I think just be able to sort of from your own, from your own perspective, recommend a local and or distal treatment plan. Just make sure you have a sense of what you would do for any given diagnosis. From a TCM perspective, so if I gave you a TCM pattern, if there was blood deficiency involved or when cold damp, how might you treat that from a TCM perspective, whether it's herbs or acupuncture? And then also from an orthopedic standpoint, what tissues might you want to aim for? Do you have to know the detail about where these motor points are? No, that's not board material. That's not even material I really got until later, but I think it's so clinically helpful, and I just want you to at least see for the first time how we kind of branch off into motor point land and use Osher points to get the most bang for our buck when we are treating orthopedically and we know what structures are involved. It's good to know where to access those optimally so that we can actually aim for those tissues. And I just also want to say, you know, if you never use a single motor point, or if you use them by accident, right? If they line up with TCM points, that's okay. TCM is really great at treating pain anyway. So, you know, if you fine tune your ortho understanding, that'll be really helpful. And I think you'll have a lot of really good success. And a handful of needles in a few of the right spots can really get someone better. So it's good to know that these things exist, but if down the line you never look at another motor point again, you know, all the points in TCM that we're familiar with will get you there. And then there's a really helpful exercise for lateral and medial epicondylitis that I'm going to show you, and I give it to my patients all the time, and it's just so helpful. So I want that on your radar. Okay. So with that said, let's start from the beginning with the mighty elbow. Okay. Here we go. So first we're going to run through some anatomy of the elbow and the forearm. So I want some voices out there, making sure you're awake and with me. How many joints actually make up the elbow? Is it just one elbow joint? Or is this elbow made of more than one joint? What do you think? How many?
I think two, at least.
Okay. Good.
3.
Okay, good. I hear a 2. I hear a 3. Awesome. It's actually 3. And 2 makes sense because of where these bones articulate, right? Where the radius and the ulna articulate with the humerus. But we'll see a 3rd in there. So just zooming out, and this will help us get there too. So which I kind of just said it, and it's right here, but which bones articulate at the elbow? What are we dealing with? The big one up here.
Well, you got the humerus,
Yeah.
ulna, and radius.
Yeah, good. I hear lots of voices. Thank you. The humerus, the radius, and the ulna. Exactly. So with this in mind, we can kind of figure out what the 3 joints of the elbow might be. So I'll give you the first. I'll just give them to you because they're kind of a mouthful, but this should be kind of intuitive if you understand the anatomy of it. So the ulnar humeral joint, that should come as no surprise that it's the joint between the humerus and the ulna. So that is about there, where that, because I know you can't always see my cursor, right? So where that red number 1 is, it's about right there. And then the second one is the radiohumeral joint, which is deep to lung 5. And so that's there. And so what's this 3rd one? Where do you think that is? There's the ulna and humerus, the radius and humerus, and then there's another plane of motion that's not just extension and flexion, it's supination and pronation.
So isn't it
So
that
it's between
the radius and ulna heads?
between
then?
the
All of you are right. Good. I love it. Yes, the radio-ulnar joint. So that's right here. So this little amazing little notch just rotates right around there. So that kind of makes up the 3 joints of the elbow. Good job. So how does each elbow joint move? So it's pretty intuitive. The ulnar and radiohumeral joints extend and flex the elbow, and then supination and pronation is at number 3 here with the radio-ulnar joint. So yeah, good. So the elbow is like, it's like a mini little knee in a way, right? And I think of the shoulders as being like mini hips. And then, ankles and wrists have a relationship. So there's a lot of similarities between these joints and they behave similarly. This is just sort of like in the knee, there are collateral ligaments. So we have in the knee, you're familiar with the ACL, the PCL, the LCL, the MCL. So here we've got a lot of ligaments, but the ones that we kind of assess for and maybe see injured most commonly are the radiocollateral ligament and the ulnar collateral ligament. So the RCL or the UCL. So it's just a rundown of where they are. And small intestine 8 is kind of in the ulnar collateral ligament territory. So you can poke around in there and get some good healing responses. And then around, lung 5, large intestine 11, and then a little further back, you can aim for these structures on the radial side of the elbow. So muscles of elbow and forearm, flexion, extension, pronation, and supination. So your antenna should come up. So elbow flexion, there's 3 muscles involved in that. The biceps brachii, so we know we have 2 heads. We've got the short and the long head of that. We've got the brachialis and we've got the brachioradialis. So 2 of those are above the elbow and 1 of those is below the elbow in terms of its trajectory. So biceps brachii, I think we all know, is above the elbow, but between the brachialis and the brachioradialis, sometimes people get those confused. Which of those 2 are which is above the elbow and which is below? Anyone know? Any guesses?
Brachioradialis is above.
Close. So brachialis is above. And I think of that muscle as kind of the soleus of the arm. So the biceps brachii, kind of like the gastroc, has like 2 heads, right? And then underneath is brachialis, and kind of like the soleus is kind of underneath the biceps. And then brachioradialis is this big chunky muscle that is just so achy right below and around LI11. Yeah, great, good. And then extension, we've got triceps brachii, and there are 3 heads there. So we've got the long head, the lateral head, and then the middle, which is underneath those 2. And there's a lot of tendon and connective tissue at the elbow there. And then the anconeus is just a little hunk of muscle. We'll see that behind the elbow. And then forearm pronation is palm down, right? So pronator teres and pronator quadratus. Those are easy because the action of the muscle is in the name. And then forearm supination is mostly the supinator, as the name suggests. But the biceps brachii has a little role in that. And if you guys and gals, you can feel that. So extend your elbow straight out and put your fingers on your biceps and just kind of rotate your forearm back and forth. And you can kind of feel the biceps a little bit, but it's a weak engagement of the muscle, right? But if you bend your elbow and now do it, now you can really feel the biceps coming in to help out. So that's what I mean by that. So hopefully you feel that on yourself. Okay, So I think with anatomy, so we don't all fall asleep. And while we're in it and while we're looking, I want to talk about where the motor points are as we're peeling these places back. And then when we talk about treatment, we'll see them overlaid with, some of the Deadman images where the points we know and love are. So you can see how those relate. But the biceps brachii, don't forget, it originates actually in the scapula. So that's why we talk about it so much with the shoulder. In two different places, right? The long head hooks down in, joins with the labrum. And then the short head is a little more medial, and it connects into the coracoid process. So the bicep flexes the elbow, and it supinates the forearm, mostly when it's flexed, as we just felt. And it also assists with some shoulder elevation just by nature of where it originates. So there's two motor points. Essentially, think lung 3 and lung 4. Lung 3 is the point where if we bring our arm across where our nose touches, right, it falls right in there. These motor points are slightly ulnar. So, and then lung 4, or the motor point near lung 4 is a little bit distal. So, if these black points were lung 3 and 4, the white points would be roughly where the motor points are. So hopefully that makes sense. And most motor points, at least the ones we're going to talk about today, are 1/2 to 1 inch deep perpendicular. There's some variation from that, but most of them are that needle depth. So you can go quite deep if you're in the right place to aim for the muscle. So the brachialis, the soleus of the arm, right? Brachialis above. So it originates in the humerus, distally on the front. And then it inserts at the ulna. It flexes the elbow. And so this point's pretty deep because it's essentially kind of underneath the biceps. So the way you needle this, it's kind of in the center, right in the center. If you draw a line, if you divide the humerus in half, it's in the center, halfway between P2 and P3. So on that line. And it's what you're going to, if you're needling it from I don't know if you can see my arm, but from between P2 and P3, you're gonna aim straight in. So that's what I mean by this little arrow there, right? So the point is here, but you're aiming your needle back here so that you can actually reach the point. So on the picture where the muscle's isolated, you'd be coming from the other direction. But this one's a little deeper. It's 1 to 1.25 zone deep. And you just got to be careful, the pericardium channel is sensitive, right? Anything on our yin surfaces. And I'm really gentle about gua sha there, if at all. Yin surfaces tend to bruise more easily. There's just more blood. So yeah, just when you're needling motor points, it's okay to go slowly. And if you're wanting to walk your patient through what you don't want them to feel. So you don't want them to feel any sharpness, like there's a needle in their arm, right? Dull, achy, heavy, like the sensation should feel bigger than the tip of a needle is what I usually tell them. Okay.
Jen,
So yeah.
I appreciate your expressions and also wanting to share with us, where these points are located. I think it would be helpful maybe if you could angle your camera to the body part that you're
that I'm showing on myself.
Yes.
Yeah, I just can't see my camera, but I will try. Yes, thank you. So I might mess around with my screen to try to make that easier. So I was just basically pointing to my pericardium, the pericardium zone on my bicep. So if you bring your hand, let's see. Okay, let me angle. Maybe I'll just, you guys don't need to see my face, right? But I do need to see my screen. Let me see if I can do this. Okay, I'm gonna have to lift up. Okay, yes, now I can see. So I was just, I was here, so halfway around here, straight in, right in this zone. Thank you. Thanks for the tip. It's helpful. All right. So here we go. These are easy. Brachioradialis, there's 2 points to choose from, essentially. Large intestine 11 or lung 6. And if you're going through from the large intestine 11 direction, you're going to thread it perpendicular, but towards lung 5. And you can go a half to 1 inch deep. And then if you're aiming for lung 6, a little further down, you can just go straight in. So those are pretty easy. And, you know, just I want to make a point to remember the actions of these, right? So brachioradialis flexes the elbow, and then it also supinates and pronates the forearm. So, yeah, it has a relationship there. But primarily it's an elbow flexor.
If you conduct in here EA stimulation, electrical stimulation.
Oh yeah. Yep.
Which one would be, is there a difference? Which one would be your positive and negative?
No, so because the and this question comes up a lot. Thank you for asking that. Each lead of our electrical stimulation devices has a positive and negative charge that are going back and forth. So it really doesn't matter. It's going to kind of alternate and go back and forth anyway. So I never really pay too close attention. That's just me. There might be other units and other devices where that matters. And in the point stimulator, actually, you do have to set it to be positive or negative. So the way most of the time I use a positive charge, and you can think of this from a TCM perspective too, right? If you are wanting, if there's some deficiency in the muscle and you're wanting to, if you know, tonify it essentially, or wake it up and bring chi and blood to it and encourage contraction and movement, the positive charge is good. I'll sometimes switch it to negative if it's like a nerve issue or like a really intense diaesthesia along like maybe the thoracic spine or like a rib or something like that, where the pain is just really excess, then I'll use a negative charge, right? But yeah, you could use both of these and you could hook one lead up and it'll just alternate back and forth.
Is there any, well, not right now, but whenever you can, could you guide us to a good source of like information, like either a book or a course?
Oh, for eStim?
Yes.
Yeah, I've been asked that before and it's tricky. I think I did find something a couple years ago, but you know, truth be told, it isn't really a source I've used. So most of my understanding just comes from my clinical training. But I will say, if you get a Pantheon machine, which is the electrical stimulator that I showed you, I can bring it back out. I think I wrote it on the syllabus. Pantheons are amazing. They're made in the US and they will service them here if anything goes wrong. And they send you a disc of a bunch of research and just kind of a thorough sort of packet of information essentially on how to use it. From a TCM perspective, though, Shanghai and CAM, they have electrical stim guidance, and that I know I review that in review and assessment. So it's part of like techniques class usually. So there's some overlap there, and I don't necessarily call on that text so much for this class because it is a little bit more TCM oriented from a perspective of like deficiency and excess. And I quite honestly find the whole explanation very overwhelming and confusing. And the only time I really remembered it was for my boards, and then I've let it go. And in practice, that's not how I use it. So yeah, I'll think about that though, and I'll throw, and if anyone else has a really good eSTEM source of text besides, you know, the textbooks that we all know and love, let me know too, because yeah, I'm not sure. And even Matt Callison's book, which I consider to be kind of like the holy grail of ortho info, there's not, I don't think there's a lot of eSTEM info in there, but I'll look actually.
For like therapy, there's an outfit. I'll have to look for it, but it's for to get certified in physical agent modalities.
Oh, okay, yeah.
Yeah, and so you know you're talking about heat and cold and
Yeah.
eSTEM and pen machine and stuff, but
Uh-huh.
so you do a certain amount of hours of online education. You know, you do the
Okay, cool.
modules, and then you have to, I think, attend the lab part and then take a test, and then
Okay.
you have to do so many patients afterwards,
Yeah.
and then you get certified as physical you know, in physical agent modalities. I have to look it up if you guys are interested.
Yeah, and if you do, feel free to throw it out there on the streaming page for everyone to take a peek at. You know, the advanced trauma and ortho certifications I've done, it's really just digging into the stuff we're talking about, and then, you know, hooking up eSTEM to muscles that you're trying to target in order to get like a therapeutic twitch response that both strengthens the muscle, and also in that repeated contraction and relaxation, it kind of fatigues the muscle too. So you're strengthening and you're also relaxing. So you're doing that with a positive and a negative charge. So it's really like this amazing like yin yang excess deficient balance. Yeah. So
Dr. Root, can I ask a quick question?
yeah.
So as acupuncturists, are we allowed to use the eSTEM without like a separate certification? Because I know like in my profession as an occupational therapist, if I wanted to use it, I actually would need to have like a separate certification.
Interesting.
Or I have to work with like a PT who is allowed to already do physical agent modality.
Right.
So I was just wondering how it is for acupuncturists.
Yeah, no, that's part of our scope right out the gate. So, and we talk about it, like I said, more in techniques. So in the context of cupping and gua sha and, you know, all of those other, I'll dig up the eSTEM bit that I kind of pulled out for my review and assessment class that goes into the TCMS aspect of eSTEM, and I'll post that for you guys. But yeah, no, we are trained on that with the rest of our acupuncture, and it's in our scope of practice. Absolutely. So you can definitely use it. You know, I think it's reasonable to be a little apprehensive about using it if you don't have a lot of experience with it. But I think for trauma and ortho and for pain, it's really helpful. And I'll tell you why. And this, so I talked about what it does to the tissues, right? But also because you're working with like nerve pathways, and there's a little bit about this in the intro lecture I did at the very first day of class. And I think in the context of getting like a twitch response and a fasciculation from a muscle, right? But you're the e-stim, the way I've been taught and told, and the way that the research that electrical stim devices have kind of laid out for those of us who use it, the other aspect, the other therapeutic aspect of it is that it helps to strongly and continuously sort of stimulate our endogenous pain control pharmacy, right? So we all have these chemicals in our brain to control pain. We don't have to always take them in a bottle, right? Don't always have to take Advil and painkillers. We have this ability. And for those of you who have tattoos out there, you know, you know this. After a long session, you know, you get this like euphoric sensation, and there's all of these endogenous opioids. You get kind of sleepy too. And yeah, there's endorphins and enkephalins and all sorts of like chemicals that get released in the brain. And when you're laying and resting for 30 minutes or so with 30 minutes with electrical stim, that sensation is a little stronger. And so it has a more lasting pain control effect because your brain has to let go, right, of these pain patterns. We know when we're hurt, we know immediately what not to do. We know, oh, we can't move in that way. And so we memorize that quickly. And sometimes it really takes time to unmemorize it. And we have to like learn how to move freely once our pain goes away. So when we're laying there and there's something from the outside passively moving these parts of our body, our brain has to sort of, you know, that guarding pattern has to let go a little bit. And that's why it can also be really just hard for patients to do. So I really encourage you to use it and start slowly with it. But, you know, in your internships and externships, get in there with it. Yeah. All right. Triceps. So the disconnected muscles over to the side of your screen, that's a little confusing. So I think put all together, it makes more sense to see how they're stacked and overlaid. But, you know, that again, this is a mini sort of gastroc-soleus relationship, right? So the lateral head, or the long head, I should say, will start in the way they're listed. The long head is kind of what it sounds like. It's the longer of the three heads, right? So it's more medial. The lateral head is on the lateral side. And then the medial head is underneath those two. So you can kind of see it poking out just a little bit in this picture here, in the blue box, between the two heads. And then they all connect to the olecranon process. So this white and yellow bit, that's all like connective tissue and tendinous material. So there are three motor points. So the lateral head is, well, I guess I should have put the long head first. That makes more sense. So the long head, meaning the more medial one, is just 2 cun distal and 1 cun lateral to the posterior axillary fold. So that's pretty easy to find. And then the lateral head is 2 to 2.5 cun lateral and slightly inferior to that. So it's basically on the other side of it, but a little bit below. And then the medial head, you've got to go through the long head to get it. So that's actually a good one because you get both. And that's a formal kind of extra point, yin shang. 3 sun above and 1 sun medial to Sanjiao 10. All of them have the same depth. But I would argue that the medial head, you'd want to go on the upper end of that depth to actually reach it. So there's those. The anconeus is a little hunk of muscle at the lateral epicondyle. So it's behind large intestine 11. And it extends the forearm. And there's an extra point there. Zhou Shu, 1 sun distal and radial from the tip of the elbow, essentially. So you don't go super deep with that. I kind of think of this motor point as like the lateral small intestine 8 in a way, because you're kind of in that zone. And these motor points are somewhat forgiving, right? We've got to have some point of reference, but yeah. Okay, almost there. Pronator teres, pronates the forearm, right? And assists with flexion a little bit. This one I use all the time, and it's super fun and easy to find, and you can teach your patients how to find it and do a little self-massage there. But pronator teres attaches to the medial epicondyle, and then it kind of twists around to the lateral side of the forearm. So you basically draw a triangle between heart 3 and P3. So these 2 black dots. And so the tip of an equidistant triangle between those 2 points is where you'll find pronator teres. So you can kind of play with that on your own body and dig your thumb in there, and you should find a nice little achy spot. And so I often have patients, you know, if you really suspect that, especially with lateral epicondylitis, that's a good point to kind of do some acupressure on. And you could put a little ear seed there for somebody before they leave, just to kind of mark the spot. But I often have them, can you see my arm and hand? I don't know. Let's see. Okay, now this is better. Okay, so what I'll do is I'll have patients put their fingers just in this hunk of muscle just below. Maybe the index finger can be on LI11, but just kind of go below there like you're playing a guitar, right? And just hold down the fret and then have them pronate and supinate their arm to get a little cross fiber massage and have them do that on their own. So that's a good way to get into that group of muscles. Okay. So this one isn't as deep. It's more in the yin territory, right? So 0.5 to 1 inch deep. And then pronator quadratus. I don't needle this often. It's a tiny little muscle, but I want it on your radar, and I want you to know about it because it is responsible for pronating the forearm. And it kind of gives distal stability to the radius and the ulna, right? So we have these like cuffs of muscle and bands of connective tissue that are supposed to keep the radius and ulna firm and in place. So P6 is tricky to needle on a good day. So this is just a little bit radial to P6, but it's deep to P6. So you got to go super slow with this, and it's 1/2 to like 3/4 of an inch deep. And I'm going to show you on my own body again. So if you find P6, and I'm going to try to make my tendons pronounced, right? Okay, so here they are. Ooh, Yeah, there they are. So here's like the P6 line, right? So we're radial to P6 with that point. So I just go to the flexor carpi tendon and you just push it ulnar and then needle straight down in there. So hopefully that makes sense. That's what I was trying to say there. So yeah, and so I put the median nerve in this picture so you could see where it is, right? It's really close. So you just got to go radial to that. And if you hit it, just back it off, move it. Just go slow. All right. Supinator. This is a tricky one, but such a good muscle to get to. I guess it's not that tricky, but it's hard to palpate, I find. You can kind of get in that zone, but there's a lot on top of it and kind of around it. But it's at the lateral epicondyle-ish, and you're gonna be distal to large intestine 11. So one of the motor points is essentially large intestine 9. So that's a really good one. And you just go perpendicular 1 inch, and you got to get deep enough to get the supinator. And then there's another point that is 1 to 1.5 cun distal and a half a cun radial to lung 5. So that one's a little trickier. And I always have to look up where that one is. Some of these complicated pathways, I honestly don't have them all straight in my mind. So don't stress about that, because one, your boards aren't going to ask you this, but two, if you care to use these treatments in your practice, you can peek at that. You can look it up and you can make yourself a little motor point chart. And it just takes repetition. Do I needle the supinator every day? No, but the ones I do needle time and again, they start to stick. But that's all it takes. It's just repetition and it'll come. Okay, a lot of this is intuitive anyway. If you palpate around the lateral epicondyle for pain there. So we're gonna talk more about the extensors next week. But I want you to know about these, because these are kind of, these are talked about a lot in treatment of elbow pain. So we've got extensor carpi radialis longus, which is that one where the arrow's going. We've got extensor carpi radialis brevis, which is behind there. And I abbreviate these. They're a mouthful. And if I'm saying I'm gua shaing or needling, I abbreviate it to ECRL, ECRB. Extensor carpi ulnaris is back there. And extensor digitorum communis, or just extensor digitorum, is that one in the center there. So they all share a common origin at the elbow. And we treat them when we're treating elbow pain because of where they travel. But what do you think these muscles do? Because they're not on the list of elbow action. So what do? Why do we care about them when we're talking about elbows?
Like extending the fingers and stuff?
Exactly. Yep. Yes. So all of these muscles attach at or near the lateral epicondyle and play a role in elbow pain. Absolutely they do. But as you can see here by this little illustration of the tear, but they primarily function to move the wrist and or the fingers. So that's why a lot of times when people are typing a lot and mousing a lot that and using their wrist a lot, or sports that involve both elbow and wrist flexion, everybody in the neighborhood's involved in that, right? So this is just kind of an illustration of how prominent this group of muscles is, even though we don't talk about them in terms of their movement or action on the elbow, because they really don't have much of an action on the elbow. But elbow pain will affect them. So we also have the flexors. So those are on the inside. So flexor carpi radialis is here. Palmaris longus is in the middle. So that's kind of the other side of extensor digitorum, right? This is big band of palmar connective tissue, where extensor digitorum was like a big band of dorsal connective tissue. And then flexor carpi ulnaris is on the outside. So all of those get really tender in elbow pain. And again, these all attach at the medial epicondyle and play a role in elbow pain, mostly medial elbow pain. But like the extensors, they actually function to move the wrist or fingers. So we won't talk about them a lot today, but I want you to know where they are, and I'm going to kind of show you how to get to them too when we talk about treatment. Okay. Well, it's 2:30. You want a quick little break? I think maybe for the first hour. Try not to log out because I'm going to take roll, but are you good with 10 minutes? Can we meet back at 2:40?
Okay.
Yeah?
Sounds good.
Good.
Okay.
Yes.
Jennifer, for previous classes, I logged out for a break, so I don't know if you missed me for the other classes. Oh, okay. I can't hear you talk. You're mute.
Oh my gosh. Yep. I turned my camera on, but not my mic. Yeah, you're all good. I got you. Yeah, for I don't think I have any absences for you.
Okay, thank you.
Yeah, you're welcome. All right. I'm back. Yeah, I just hello. I just peeked at the chat. And yes, Fu does a lot of eStim. So yeah, if you can extern with him, that's a great way to get comfortable with it. You know, Anthony did a lot of eStim too. That's who I started to learn from, and I do eStim most of the time for ortho. Again, just and maybe I didn't emphasize this when we were talking about it last, but assess the patient too. You know, are they really deficient? Are they really sensitive? Nerve issues like numbness and tingling, eStim's amazing for that. What do we need for proper function? We need blood flow and we need electricity, right? And blood flow essentially can help restore nutrition to those nerves that may be choked out or damaged. But, you know, adding a little eStim in my mind is like watering a plant, right? So if nerves are involved, we definitely want to give them the chi they need, right? So I brought out my Pantheon to just show you again. So this is the one I use, and I really, really like it. I've used a lot of different electrical stimulators along the way, and this one I think has the tightest control. So yeah, hopefully you know what I mean by that. Sometimes with the other units, the less expensive ones, you know, you get nothing, and then all of a sudden you get a blast and then you dial it back. And, you know, some of that depends on where you are in the tissue, but these are just really, really well made and very, the stimulation is really well controlled. And these are the clips I like to use. So these go around the needle like that. So the needle fits in between them. I don't know if you can see against my forehead, but anyway, lots of different clips, but those ones are my favorite. Oh yeah, they're very expensive. Yep, Javier. Yeah, super pricey. I only have one of them. But I put it on your syllabus, so if you can allocate funds while you have them for it, then you might as well. But yeah, they're great to have, but yeah, you need a piggy bank. And you know, you don't need the fancy one. I just have the 4-channel, and it's great. And it's not, you know, it's not complicated for patients to use. I often have them set their own levels. And so the fewer buttons, the better. And it does a great job. Yeah, I so agree with you, Molly. It's so true. They do. With the little alligator clips, especially when you're getting in there and like a really tight clearance, sometimes they like twist accidentally when you're squeezing them. You know, you'll lose your grip and they'll just twist, and you don't want to twist the needle. So these are more springy to connect and remove. So there's less pressure involved in opening and closing those clips. They're called easy grip or easy clip, like easy clips. I think Lhasa has them. Okay. Let's jump back in. Okay, so I'm not going to bombard you with elbow ailments because, again, you know, just the basics, so you have a good idea of what you're most commonly going to see. So here's a little list off to the side there. So lateral epicondylitis is tennis elbow. That's this tennis action moving laterally. It's 10 times more common than medial epicondylitis, and I probably agree with that. See it all the time. So there are 3 tests you can do. EDC resistance. I forgot to take that out. I'll tell you what it is. It's really an easy test, but I decided to eliminate it at the last minute because Cosen's and Mills are really the 2 that you want to know. I'll talk about that in a minute. So lateral epicondylitis, I want you guys to know the causes and effects of these signs, symptoms, all of that. What does it look like and why does it happen? So the cause for lateral epicondylitis is overuse of wrist extensors and supination. So racket sports like tennis, right? Prolonged typing, and then trades like carpentry, plumbing, electrical work, screw driving in both directions will have an effect on either side of the elbow, but this is particularly supination. So yeah, know that. And it's going to be like a sharp fixed pain at the lateral epicondyle with like a dull ache kind of between LI11 and LI10, right where I kind of showed you to do that cross fiber massage, mostly at rest if the pain is kind of dull. But then if the patient uses it, it might kind of tend to be more sharp. So the pain is often triggered by active wrist extension or flexion, and may be reported while opening doors, lifting a coffee cup or a soup bowl or a spoon or something like that. Shaking hands can be pretty painful. And so extensor carpi radialis brevis is the most commonly affected muscle, followed by extensor carpi ulnaris, and then extensor digitorum communis, hence the EDC resistance test. So that's kind of the confusing thing about the elbow, right? Because we learn, and I want you to know that. So there are muscles that are responsible for elbow flexion and extension and pronation and supination, but in lateral elbow pain and in medial elbow pain, most of the time, the muscles that move the wrist and the hands are the ones that are the culprit. So if you're wanting to do like a motor point approach and treat those tissues that are involved, the extensor group is a good group to needle. And then, you balance that. We balance yin and yang by saying hello to the antagonists sometimes. Because every muscle action, every agonist has an antagonist. So every time a muscle contracts, another one has to lengthen. So it's good to kind of balance those. And I'm just in practice, again, don't worry too much about it, but it's just, I want you to understand sort of how to think about all of this stuff. And what relationships the agonists and antagonists have. Am I going to make you memorize them all? No, it's not anatomy. But clinically, this is here for you to call upon in the future. Teres major is another good supportive structure, just because of the actions that are often involved in lateral epicondyle pain. So you could do classic local points anywhere between large intestine 7 and 11. That whole line is great. Lung 5, P3. The flex bar exercises that we're going to talk about later, that's amazing for lateral epicondylitis. And you will get much faster results if your patients are doing that between visits. So I'll tell you about that later. And again, topical herbs, tuina, gua sha along the extensor wad, essentially the LI channel-ish. You can spill over a little bit from side to side, but that's primarily the channel. You want to gua sha, and you always want to go proximally, right? You want to go up towards the heart. You want to help the blood get where it needs to be. You do not want to damage those one-way valves that are working so hard to bring the blood up to the heart against gravity. So please, 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 when you're working on the limbs, remember that. Go towards the heart. Otherwise, you can bruise people and you can irreparably damage some of those valves. I've seen it happen. Yeah, so just be mindful of that. And e-stim, always a good idea. If you get, and I'll try to talk about e-stim as much as I can along the way as it's applicable, since it seems to be a little bit more ambiguous. If you're needling a small intestine 8, for example, and you get a really strong nervy kind of sensation, you of course want to back it off. Our intention is not to traumatize nerves, but we want to be in that area. So just be careful with e-stim along when you're in the direct pathway of these nerves, because as the needles are moving, they could shimmy in a little deeper, or they could, they could actually come out in the course of those twitches. So you want to make sure that those contractions, you have enough room there for that play. So if you're close to a really powerful nerve and it shimmies in a little bit, you don't want to continuously stimulate the ulnar nerve and damage it. So it feels more comfortable to the patient in muscles rather than nerves, right? And in places where it's just kind of dull and heavy and achy, and we don't want sharp. Okay, so Cosen's test is the primary test for lateral epicondylitis. This kind of can take a minute to get because you're doing a couple things at the same time. So the patient makes a fist while extending the wrist, so upwards, and then deviating to the radial side medially. And so you, as the practitioner, you've got one hand on the lateral epicondyle, and then with the other hand, you're just basically trying to break them out of that. It's a break test. So you apply pressure to the back of their hand, attempting to bring the wrist down into flexion, and then ulnar deviation against resistance. So let's look at that because it's a little confusing in words, but if it reproduces pain, it's positive. Here's our friend from Physio Tutors.
Hi, welcome back to Physio Tutors. The Cosen's test is designed to maximally flex and thus provoke the extensor carpi radialis longus and brevis. To conduct the test, have your patient in a comfortable position and stabilize his elbow while you palpate his lateral epicondyle with your thumb. Then ask your patient to make a fist, pronate his forearm and radially deviate, and extend the wrist while the examiner gives resistance. This test is positive if your patient complains about sudden pain at the lateral epicondyle. All right, guys, this was the Cosen's test to test.
Yeah, so it's simple, but it's a mouthful when you look at it. So, all right.
This is good.
Oops. Okay, so this is the Mills test. So this is more of a passive range of motion test. So, you're doing a similar thing, but what you're doing is rather than having the patient engage muscles against your resistance, you're doing the action that you just did more passively. So I hope that makes sense. So we'll look at that. But same idea, you palpate the lateral epicondyle and you extend the elbow, flex the wrist with ulnar deviation, and you just kind of put it on maximal stretch. And if it produces pain, then it's positive. So here's another way to do it.
Is you pronate the wrist, flex the wrist at the same time while extending the elbow. And if the patient complains of discomfort at the lateral epicondyle, that is a positive Mills test. It's good that you follow that up with a palpation to that region to make sure that is the source of your discomfort. And also make sure that you do a Cosen's test to help confirm the diagnosis of lateral epicondylitis. So that is how to perform the Mills test. You flex the wrist, extend the elbow at the same time. You're looking for pain at the lateral epicondyle. Please make sure you subscribe to our channel and like our video.
All right. So that's the Mills test. And then we've got medial epicondylitis, right? So actually, before we go on, before I post this lecture, I'll delete the EDC test. But basically, extensor digitorum communis test. This is a test for lateral elbow pain to determine if that muscle is involved. Like I said, most of the time it is. So, you know, it's not going to be harmful to treat it, but it's really easy, actually, the EDC resistance test. So it's like it sounds. So you have the patient, their forearm is pronated, and then you push down on the middle finger while they resist. So that muscle, the extensor digitorum communis, kind of goes here, and then it fans out to the fingers. So the middle finger has the most power along that line. So if you basically just have them resist and then it produces pain at the elbow, that's a positive test. Okay. Where were we? So medial epicondyle pain. Medial epicondylitis is golfer's elbow, right? So it's the swinging medially. So this is overuse of the flexors instead of the extensors, and pronation rather than supination. So golf, throwing sports again, especially like, it depends on the direction you're throwing, but a lot of times, you know, there's this sort of medial direction to a pitch or a throw. Swimming, rock climbing. You see a lot of rock climbing injuries around here. Carpentry, again, with the hammering and the screwdriver and other hand tools. This is common. So it's similar. It's just on the medial side, right? So sharp fixed pain. This, it tends to be a little sharper, I think, than lateral epicondylitis. It's often triggered by activity or flexion, right? Elbow flexion. So, you know, like, again, the typing, the texting, you know, the bending the elbows, the sleeping with the elbows flexed, all of that stuff is going to kind of just exacerbate it a little bit. Flexor carpi radialis, ulnaris, pronator teres, and palmaris longus are all often involved. Again, notice how we're talking about these muscles that move the wrist, right? And not so much the elbow. But, you know, we got it. There's so much overlap. The ulnar collateral ligament is more commonly sprained than the radial. I mean, at least I shouldn't say that with any authority. I see that more, but I don't know statistically if that's true. But it's just good to assess for laxity in that area. I think you could probably make a case that it is a little more common to strain or sprain that ligament. And that's kind of, that's the purpose of Tommy John surgery that a lot of pitchers get. They basically, I think I talk about this somewhere, but they harvest a piece of the gracilis or palmaris longus tendon usually, and then they go in and they patch up the UCL. Okay. So the agonists are these flexors and pronators. The antagonists are the extensors and supinators. Classic points would be small intestine 8, small intestine 7, small intestine 5. This whole line is great. Heart 3, pericardium 3. And then you could, I think gua sha along the small intestine channel is therapeutic, and that's fair game. And you can kind of hang out along where the anconeus is and the lateral epicondyle too a little bit. Yeah, along the small intestine channel, especially closer to the elbow, gua sha is more therapeutic, but be careful again on the inside because it tends to just hurt a little more. It does, and I think we all know this, right? From our own treatment experiences, it doesn't feel great to have your inner thighs gua sha'd or the yin aspect of your arm. It's more of a yang tissue treatment, but I love gua sha. Okay, medial epicondylitis, it's basically the reverse Mills. So it's a passive test. You bring, I'm gonna show you how to do it, but there's one thing he shows you an action, but he doesn't really vocalize it. You passively bring the patient's elbow and wrist into extension with the forearm supinated, so straight up. And then you maximize the stretch at the medial epicondyle by leveraging your motion from the palm. So you kind of like push down and extend the fingers, right? While you're also extending the elbow and wrist. So he does that here, but yeah, don't forget to, and you can feel that on your own body, right? So if you extend your elbow, if you push down, well, it's kind of, I guess, hard to do if you don't have support under your elbow, but if you just push on your fingers, you really feel the stretch through that area versus just pushing on your wrist. So we'll look at that real quick.
Hi and welcome back to Physio Tutors. This test is designed to maximally stretch and thus provoke all the muscles that originate from the medial epicondyle and that attach distal to the wrist. To perform this test, have your patient in a standing position, fixate your patient's humerus, and palpate the medial epicondyle at the same time. Then passively supinate your patient's forearm, extend your patient's wrist, and extend the elbow fully. Okay. This test is positive if your patient complains about sudden pain at the medial epicondyle. Okay, this was our video.
So yeah, I mean, he said what I said, and he did what we talked about. But as you can see, he's sort of, his leverage is from the fingers, not the wrist. So that's important. Okay. So cubital tunnel syndrome, ulnar neuritis is another common one. So this is like numbness and tingling, right? Down the ulnar nerve, reaching the pinky. So that can sound a lot like a cervical spine radicular pattern. So it's good to make sure, your patient might say they have pain in the medial elbow or anywhere in the elbow with tingling, but anytime you hear tingling or numbness along fingers that overlap with the cervical spine, just quickly have them do the range of motion of the neck just to make sure that doesn't trigger their pain. And if it does, then the source is probably not the elbow. But it's the punchline for cubital tunnel syndrome or ulnar neuritis is soft tissue entrapment of the ulnar nerve. So this is common in activities that require flexion, extension with ulnar and radial deviation of the wrist. So that's pretty much every plane. And that puts valgus tension on the medial elbow. So valgus and varus tension we'll talk about, but the elbow doesn't like to move medially and laterally, the joint, right? It's a flexion and extension action, kind of like the knee. The knee does not like to go medially and laterally. And sometimes if there's trauma or in sports, you can kind of get hit from the side and, you know, that elbow or the knees can bend in the ulnar or lateral or medial direction, right? So valgus tension is basically like if you were folding the elbow in this plane out to the side. Well, I'll show you what that looks like better later. But this is a common in musicians, right? So the fret hand reaching around like the top of a guitar or a violin or something like that. So because the fingers and the wrists, they have to engage to hold the strings in place. And then the arm is supinated and pronated, right? And so the elbow and wrist, they're in flexion. And that contracts the flexors and puts a lot of strain on the attachments at the medial epicondyle. So pain in the medial side of the elbow with numbness and tingling along the ring and pinky finger. That's what they're going to report. Symptoms may be triggered by elbow flexion. So driving, talking on the phone, texting, sleeping. So I often tell patients, even if they don't have numbness or tingling, especially with medial elbow pain, medial and lateral, try to have them avoid, talk about sleep posture and try to have them avoid squishing the elbows into flexion all night long. So it doesn't take much to remind us to do something in our sleep. We're not going to try very hard to roll over something or break out of something, usually. So like some self-adhesive gauze or cutting a sock or something like that, just so there's a little bit of resistance to remind the person not to flex the elbow during sleep. So again, flexors are involved in this flexor carpi. You would treat it similar to how you would treat medial epicondylitis. So you also palpate distally along the small intestine channel, and then the entrapment is usually about 1 cun distal to the medial epicondyle. So if you find kind of a tender spot around there, you can kind of like superficially needle towards or away from the medial epicondyle in whichever direction you're finding those tender points. So just like a line from small intestine 8 distally around here. But yeah, again, differentiate from thoracic outlet syndrome or a C8 cervical nerve impingement. So the test for this is super easy. It's a Tinel sign, like we kind of do for carpal tunnel, but instead of tapping over the carpal tunnel, we're tapping over SI8. So 4 to 6 times in the ulnar groove between the olecranon process, so the tip of the elbow, and then the medial epicondyle, that little bony bump right in there. Boop, 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 boop. And if that reproduces paresthesias down to the ring and pinky fingers, it's positive. So this is another test. I couldn't find a good picture anywhere else other than Matt Callison's book, but you flex the elbows, externally rotate the shoulders in slight abduction with wrists extended and radially deviated. That's crazy. Don't worry about memorizing that, but you basically pretend like you're a waiter or a waitress holding a service tray right above your shoulder, and that'll get you there. Just like this person in the picture. So with these, some of these tests, this is similar to like the Phelan's test, right? Where you're putting the nerve on maximal stretch. You're creating a lot of pressure in that little space, and you're waiting for a certain amount of time for that to cause symptoms. So 3 to 5 minutes is a long time. I don't know that I've ever had anyone do that for 5 minutes, but if you kind of know that while you're talking, have them do that, and you can continue your conversation and do the intake while they're in this position, and their arms might get a little tired, but keep an eye on the clock and make the most of your time. You don't have to sit there in an awkward silence for 3 to 5 minutes. Or while you're doing gua sha on the neck or the shoulders, have them do that, so it's positive if it reproduces tingling. So we've covered the lateral and medial side of the elbow, and now we're going kind of to the posterior side. So triceps tendinopathy, not super duper common, but it can be. Repetitive forceful elbow extension is usually what can traumatize the tendon of the triceps. And like you saw in the pictures earlier, it's a big band of connective tissue there. So weight bearing activities, if you jump into something that you're not quite ready for, that can really put pressure and stress on the triceps tendon. Or especially forceful eccentric lengthening. So eccentric and lengthening are the same contractions. So that would be like a push-up in the downward phase. So even though the triceps kind of contracts with extension, and this goes back to the very first lecture we did, if you're lowering yourself down very, very slowly in a push-up, that's good for your muscles. It's a good way to build strength. But while the muscle's lengthening, it's engaged. So that's the most simple way I can put it. But anyway, a push-up. And then, a backhand stroke in tennis can do that. So anything that causes elbow extension kind of dramatically. So pain at the distal triceps tendon insertion in the region of Sanjiao 10 is where that pain is going to be. It can also be near the lateral epicondyle. And it kind of like blends into the area of the anconeus. So, triceps tendinopathy can look like lateral epicondylitis. So just know that that should be a little bit part of your differential, especially if, the patient doesn't really report pain along Sanjiao 10. It's mostly in the lateral epicondyle. And maybe you do the Cosen's test and, the Mills, and you're not getting much. Then think about triceps tendinopathy. You can still treat the same structures you would in lateral epicondylitis, but you'd also want to treat the triceps itself. So, and gua sha along the triceps is very, very strong, but kind of like the IT band, it's that sort of sensation. So you got to be kind of careful, but it can be really therapeutic. So just start lightly, again, towards the heart. So this is where we treat the triceps, the lateral long and or medial heads. The biceps brachii is the antagonist to that, as is the brachioradialis, actually, the one, not the brachialis, but the brachioradialis, and its relationship to the lateral epicondyle. So classic points, Sanjiao 10, Sanjiao 11, LI 11 and 12, all of those back there. Similar. I have to say, in my experience in the last little bit, elbows tend to really respond well to topical CBD. I don't want to open a we could talk about CBD for a while, but my elbow patients really like the topical CBD for some reason. Mixed results in other joints. We have amazing topical choices in TCM. So it really depends on what our goal is and what tissues we're trying to reach. But yeah, CBD and elbows. That's just what I've seen as of late. So the triceps test is more of a manual muscle test. I don't think it has any sort of special name. It's pretty easy and straightforward. You flex the elbow, not all the way to 90. You can have the patient lay down and do this, but you flex the elbow to 80 with the arm supinated, so the palm is facing up. And then you bring the patient's elbow into flexion. So essentially you visualize moving P6 towards the shoulder, right, against the patient's resistance. So you want to compare sides. And then there's a recap of how you chart that. So 5 out of 5 is full strength, doesn't cause any pain at all. 4 out of 5 is it is a step down from that. Partial range of motion against resistance. So you can kind of feel a subtlety between two muscles if you test them both. So you might not be able to completely break the patient out of that, but you might feel a subtle weakness, or they might feel strong to you, but the patient says, oh yeah, you know, I can do it, but it hurts on the right. So just to show you, try to show you. So you're flexing the elbow to 80, not 90, right? So you're flexing it a little bit more, and then supinating, and then you're bringing P6 to the shoulder against their resistance, right? So we can do that on ourselves, and we can really feel the triceps engage back here. Okay. Oh, all kinds of stuff going on in the chat over here. Thank you, everyone, for those wonderful tidbits. Okay. So we're doing good. Okay. So olecranon bursitis. There's a picture of it. It's usually caused by direct trauma or prolonged pressure to the elbow. So it's called like student's elbow too. So just resting on our elbows on a desk, or if somebody rests and talks on the phone. Most often I see this from a direct fall on the elbow. So it's pain and swelling just at the tip, just like that. Swelling is usually pretty apparent and diagnosed by observation. So there's a good picture of it. It can be pretty dramatic. So I want you to see it and be familiar with it if you're not, so that you don't worry too much. Patients often worry about this because it can be pretty painful and dramatically swollen. So you're treating around it, okay? So you want to treat the triceps and anconeus if you can get to them in the small intestine, or sorry, the Sanjiao zone in the back of the upper arm, and then biceps brachii and brachioradialis. You can treat those two, and then turtle technique. I love the turtle technique. Wei Long Tzu technique. So you basically surround the perimeter of the swollen bursa with 6 or 8 needles, but don't pop it directly. I am a fan of 7-star and I do it often, but you got to be kind of careful. Different practitioners might say different things, but I'm a little bit careful with olecranon bursitis. The skin is really thick there too, and turtling it and needling around it, you can even do a little e-stim around the area. That can have a remarkable, substantial effect. I had a patient maybe a month ago with quite it was a snowboarding accident, and they had quite a swollen, they clearly had olecranon bursitis. And it just took one treatment with turtling, and they were like, I'm better, it's gone. So it can be really, and I do this too around like bee stings or really dramatic bites, like a mosquito bite or something where like the area is swollen. Just turtle it around, and hematomas too. And what's really amazing and incredible, sometimes with bites and hematomas, you can 7-star as well and then turtle it. And by the time you come back in the room to get the patient up, you can often see the swelling retreat away from the border. It's the coolest thing. So here's where we have to just tune our attention to red flags. So this is rare, but bursa can become infected, which can lead to sepsis. So that's also why I'm kind of careful in this region. In this case, it's going to be, if you Google pictures of olecranon bursitis, you're going to see some crazy photos, much more severe than this. This is probably about what you might see walk into your office, but it's going to get really red and really angry and really hot and really painful. So anytime, you don't want to freak your patients out, but you really want to let them know, like, hey, if this goes on and you start to feel a little sick, if you have a fever or anything like that, let me know, or get yourself to urgent care. And then they can have it aspirated and drained and prevent an infection in the blood. So it's a red flag there. And then I think last but not least, just going back to the lateral coligaments. Collateral ligaments. These are from trauma, dislocations, foosh injuries, falling on an outstretched hand, contact sports, and UCL injuries are very common in baseball. And I like baseball. So they're on my radar, but tears, like we've talked about time and again, there's different spectrums of tearing. So, a grade 2. So there's a sprain, which is just a little stretch. And then there's, an extension of that would be like tiny little microscopic tears to these ligaments. And then that causes laxity in the tendon, and then that can't hold the humerus and the ulna tightly enough together at the top of the joint. So when you throw, those two bones are a little loose, and then that's going to wreak havoc in all of the soft tissues and nerve pathways along there. So anytime, there's a lot of like clicking, catching, that kind of thing, think about the ligaments or tendons. Same thing with labral tears, right? So numbness and tingling can accompany this. So again, if somebody presents with medial epicondylitis with numbness, you want to differentiate and again, rule out the neck or thoracic outlet, but you also want to just check the stability in the medial and lateral planes of the elbow. So, here it is. In extreme cases of UCL tear, Tommy John surgery may be required, in which a portion of the palmaris longus or gracilis tendon is harvested as replacement tissue. It's pretty cool, but let's try to avoid that. So partial tears, they can take a long time to heal, but we can speed it up. So we're talking several months, at least 3 months, perhaps. But it's hard to say, especially if we don't know for sure. But a patient's response to treatment is also diagnostic. And so if after 3 to 6 visits, they're not getting substantially better, but kind of better, we might think, oh, well, there could be a little tear here. So you treat it similarly to medial or lateral epicondylitis, depending on which side, whether it's the ulnar or lateral collateral ligament. So when we're trying to tighten up ligaments and tendons and, that kind of connective tissue that's unlike muscle, it's poorly vascularized, poking at it, you do, Anthony always used to describe it as needling into chewing gum, and you kind of get that sense. And if you poke around and just use a little pecking technique in these ligaments, you can start to feel it tighten up under your needle, and it's amazing. And you can use 2 needles at a time and twist them together a little bit too, at the handle, and just kind of encourage them to grab onto that tissue. And then I haven't talked too much about this technique in a lot of detail, maybe a little bit in the shoulder, but when you're aiming for ligaments or tendons and your goal is to tighten up a torn tissue like this, when you get where you need to be and you feel that ligamentous material, the patient's going to report likely like a dull, heavy ache, not sharp, but dull, heavy, kind of satisfying ache. Depending on their interpretation and perception of that, but that's what you're going for. And then you can wind the needle, right? So wind it clockwise, and then wind it counterclockwise. And wherever you get the most resistance, keep going and just keep twirling it, right? So you're winding these fibers all together and then leave it be. So we can do that. We can stick our little needles in there and like cotton candy, kind of encourage these fibers to heal together and get stronger. Okay. Valgus and varus. This used to drive me nuts. So it's not that bad, but if this is your first experience with valgus and varus testing, just be patient with yourself. So valgus stress is testing the ulnar collateral ligament. So the ulnar collateral ligament is on the medial side, but I remember this because you're sort of bending the elbow laterally. So L valgus for lateral direction, even though you're testing the medial side, right? So super easy. Patient's shoulders in neutral. You have the forearm supinated and slightly flexed. Some people say 30 degrees. That's kind of a lot. Others say 10 to 15. I don't care, just slightly flexed. Maybe there's a nuance there that I don't know about, but just a little bend. And then you put one hand on the lateral side of the elbow joint between large intestine 11 and 12, just like in this picture. And then you put your other hand on the inside of the wrist between heart 4 and 7, just like in this picture. And then you apply medial valgus force on the lateral side of the elbow while simultaneously applying lateral abduction force at the medial wrist. That's so crazy and like it's like a tongue twister. So like I say here, I know that's confusing. Just pretend like you're trying to fold the elbow sideways with the top of the fold at the ulnar ligament, like this. So in that direction. And elbows don't bend this way, right? They don't like to. They're not supposed to. So be mindful of how much pressure you're applying there. But so yeah, that's valgus. And then varus. I didn't animate that quite right. That's funny. Wrong picture. Other direction, right? So patient's shoulders in neutral or internally rotated slightly. So, okay, I say or internally rotated because I'm going to stop sharing. So if you're testing the lateral collateral ligament, sometimes for leverage, it's easier to have the arm or the shoulder internally rotated. So the empty can action. So if you do that, then you have more leverage in that direction to test the lateral elbow. So you can have it in the same position and bend it this way. But if you have it internally rotated, you know, you might get more leverage. You can do it either way. Okay, let's see. Now I have my eye on the chat here. What are the valgus and varus in the knee? Similar, but I don't want to talk about knees quite yet, but it's the same thing. So when you're testing the MCL and the LCL, you're doing the same thing. You're kind of folding the knee, and it's easier to grab the knee actually, but you're applying the same principle to the knee as you are to the elbow in that case. And Lauren's question, yeah, weekly treatments are great. 2 to 3, like twice a week for a few weeks is ideal if you know you're dealing with a tear. And then you can, you know, dial that back to once a week. If you're like me, oh my gosh, there's no way I can see someone twice a week. I'm lucky if I can see someone once a week. So, yeah, it's tricky if you're super busy. You want to get those patients scheduled ahead of time in that right frequency, but more treatments in a shorter time between is ideal at the beginning, especially when you're working through like a ligament or tendon injury or a tear, because you know, you're going to assume with everything else in ortho, you're going to release your patients back into the wild after they come and see you, and they're going to do these actions that are going to kind of contribute to the pain in the first place. So you're slowly kind of like, you know, I explain it like we're pushing this big boulder up a hill and we don't know how high the hill is or the mountain is or how heavy the boulder is. So you don't want to start from the beginning every time. You want that baseline to continually creep up and improve. So I hope that helps. Okay. All right. Okay. So does anyone have any other questions about valgus and varus stress? These are pretty good photos with the arrows. And there's videos, but they're not all that much more helpful than these images because the movement is so subtle that it's like you can't really see what the person's doing so much. You might get a sense of where they're holding the arm, but yeah, images are a little more helpful. All right, so we're going to jump into treatment methods. So maybe I'll give you guys another quick little break. Can we meet back at 45 is a little soon. Can we meet back at 3:44? Is 3:45 too soon? Do you guys need a little more time? I just want to finish up the elbow today and have a little time for the shoulder.
That's fine. Thank you.
Yeah? Okay. Awesome. Okay. See you at 3:45. All right. Hello again. Home stretch here. Okay. So let's see. Oh, there you are, Skylar. Okay. Skylar's here. Was Carrie out today? Don't see Carrie out there. And Amy. Okay. All right. We're back. So we left off at treatments, and I just can't thank you all enough for being patient and constructive with my first time around teaching. You know, in any presentation, sometimes you think, you know, you have in your head how things might go, and then in practice you're like, maybe I should have done that differently. So last week, I know we really rushed through at the end, and there was a lot of redundancy too. So I'm kind of like, you know, reeling it back a little bit. And so we're going to talk about treatment approach, and I'm going to try to continue to follow the way I'm about to do it. And then we'll end, I'm assuming we'll have time with just kind of touching up where we left off with the shoulder, since we just ran through that so quickly. And then it'll be easier to connect those dots and maybe not so overwhelming. So with that, treatment. So treatment of the elbow. And again, we're going to talk a little bit about TCM, pattern differentiation, and tissue pathology. So this is like my favorite part, you know. So I'm just going to jump into the points because we talk about them as we kind of look at treatment protocols. And my preferred way of reviewing these points and some of the extra points I'm showing you is through these Deadman summaries, where you can see all of these in relation to one another. But these summary of points don't always have the body part or the visual that or the other points. So sometimes there's no context to do it here, but when I can, I'm going to use Deadman to sort of overlay some of these points. But for the shoulder, I think I literally took photographs of my book and just like popped them in there for some of those extra points, because we didn't have a good summary necessarily. But so points of the upper arm. So we talked a little bit about how some of the muscles on the upper arm have an effect on the elbow, primarily the biceps brachii. And so here's the motor point in relation to P2, right? So it's just a little bit medial to it. So it's pretty high up there. That's the short head on the medial side. And then the long head has two. So we looked at this at the beginning of class, but this is not in an actual muscle on a skeleton. This is on the surface of the body as you're going to try to locate the points. So a little bit ulnar to lung 3 and a little ulnar and distal to lung 4. So those are where the long head bicep points are. But again, you'll be fine with lung 3 and 4, you know. Motor points are handy. Like I said, if you really want those twitch responses, you might still get one in lung 3, especially with some E-stim. But looking at muscle anatomy and where those nerves pass through and where you're going to get that maximal electrical response is in these little refined locations. And sometimes I will add, as I'm kind of like palpating the structure I'm aiming for, the place that I feel in the tissue on the surface, like I want a needle therapeutically, often lines up, but I don't know what percentage of the time it lines up with TCM points or what percentage of the time it lines up with motor points, but they're good to know because sometimes I'm like, I don't think there's a traditional point there. It's a little distal and lateral and superior to inferior to that. So you can chart it that way. You can say, you know, lung 3, you know, 0.5 lateral, or Oh, there's a motor point there. So anyway, okay, so brachialis, we talked about this too, but this is the one that's halfway between P2 and P3 going straight in. Yeah, so that's what it looks like on the arm, right? So it's behind the bicep. So you have to kind of get it deep enough to reach it if that's what you're aiming for. So that was that's the upper arm. There's not a whole lot up there in the way of elbow points. Down here on the medial and lateral forearm, there is. So sometimes, like I said, motor points line up with traditional points. So the motor point of brachioradialis lines up with large intestine 11. The motor point of extensor carpi radialis longus is large intestine 10. So again, you don't need to worry about these because traditionally, if all you knew were our TCM points, chances are you'd needle LI 11 and 10 for lateral elbow pain and you'd be fine and it's great. The supinator, one of those is deep to large intestine 9. So that's about there, but you have to go in close to the bone. That one's pretty deep. And then the motor point of Anconius, remember how I said it's sort of kind of like I see it as like the lateral small intestine 8-ish. So it's one cun distal and radial from the tip of the olecranon process. So it's in that zone. And then kind of radial to that is extensor digitorum communis. So the way you find that point is similar to how we found pronator teres. So it's you make a triangle from large intestine 8 and large intestine 9, and then the equidistant tip of that triangle here is the motor point of the EDC. So that's a good spot to do. And then extensor carpi radialis brevis, that's 0.5 cun ulnar to large intestine 8. So you're really on this line. You really can't go wrong in this line between LI 7 and 11 for lateral elbow pain. But if you just shimmy a little bit to either side, you might get better results if you know where these structures are. Extensor carpi ulnaris, 0.5 cun ulnar to Sanjo 9. So that was that for those points. There are a lot of them squished in there. And then medial forearm. Okay. So the motor point of brachioradialis, again, large intestine 11, which isn't shown on this picture, but it's about right there. So like I mentioned earlier, you can thread it towards lung 5, a 1/2 to 1 inch deep. And that's one way to do it. Or you can go down to lung 6 and you can go perpendicular straight in at lung 6 to get brachioradialis down there as well. Pronator teres, that's the one I was just talking about. So again, our equidistant triangle locations, pronator teres is between heart 3 and P3, an equidistant triangle. It's a little bit of a smaller triangle ish. And then the supinator has 2 motor points, 1 to 1.5 cun distal and a 1/2 cun radial to lung 5. So you can see that relationship here. And then, or deep to lung 9, which is about there. It's not on this picture, but it's 3 cun down from LI 11. And then flexor carpi radialis, 3.5 to 4 cun distal from pericardium 3. So if the line that you're on is between P3 and heart 7. So it kind of curves ulnar a little bit, ulnarly. So that's here. And then, so there's a nice little diagonal strip right around here. Palmaris longus and flexor carpi ulnaris. See, that's what I mean by that little diagonal line right here. If you kind of break the lower forearm on the ulnar side into thirds, it's the junction of the middle and proximal third, that line there. And in palmaris longus, that line is between P7, so in the center of the wrist, to the medial epicondyle. So it curves a little bit that way. And then you have another line from heart 7, so a little further over. But, you know, this whole zone, flexor carpi radialis is a little easier to find, and then you just kind of go diagonally from there. But you should find some tender points in there that'll kind of guide you. Oh, yes, and pronator quadratus, deep and slightly radial to P6. So that's the one. You want to be careful, and you want to move this tendon to the ulnar side and just go straight and really, really slow. Just being mindful of the median nerve. Oh, yay. Okay. The flex bar. This is the exercise I was telling you about. So this is called the Tyler twist. There's the Tyler twist and the reverse Tyler twist. Again, like I said, the lateral epicondylitis is 10 times more common than medial epicondylitis, but sometimes you get them together. In patients, I see them coexist. But you can do the same exercise in the opposite direction for the medial side of the elbow. But this is what a flex bar looks like. It's made by TheraBand. You can get them on Amazon or at a lot of like massage or sports medicine supply places. And this is how you do it. It's very easy.
Hi, this is Jill from ProPhysio.
I send patients this YouTube video, and here's the link. I send it to them all the time, and then on the next page I have a visual, so you can print that out and give it to them, but it's kind of nice to see it.
Today I'm here with Emily to talk about a treatment technique with the TheraBand Flex Bars for lateral epicondylitis. So I'm going to go ahead and hand this to Emily, and then I'm going to step out of the way so I can describe how to do the exercise. So Emily's been having some tenderness on the outside of her elbow. So what we're going to do today is she's going to hold the flex bar vertically with the arm that has the tennis elbow. She's going to reach across and grab the bar with the other hand, palm facing outward. Then she's going to keep the injured arm still and twist the bar clockwise with the top hand. Next, she's going to maintain the twist while extending the arms and turn the bar horizontally. Now, nice and slowly, she's going to untwist the bar using only the injured side. This is a really good treatment to eccentrically elongate those wrist extensors and treat people that have this lateral epicondylitis. The goal would be 3 sets of 15, but you would stop and work within your pain limits and go at your own pace. If you're anyone you know is in need of this kind of treatment, please look us up at
So yeah, it's you know, at first glance, it might be a little overwhelming, but it's very simple, especially when patients get used to it. And I promise you, I mean, if you're really dealing with lateral or medial epicondylitis, it works wonders. It's kind of like internal gua sha. You know, it's just kind of untethering adhesions from all those attachments. I mean, there's a lot of muscles that attach to the lateral and medial epicondyles. So this is a really good, really effective, and it's going to make your treatments a lot more effective. If they can, anything they can do when they're not in your office is to heal themselves is ideal, right? So this is kind of, you can find this online too. There's a lot of handouts, and some of them have photos of people doing it, and they're lengthy. This is a quick one-pager, but if you Google the Tyler twist, you should be able to find handouts readily available online. But this kind of shows you the reverse Tyler twist as well for medial epicondylitis. So this is just a written and picture cartoon of exactly what she just showed us. So elbow pain and TCM, it describes a handful of concepts. So elbow taxation, Zhoutong, tennis elbow is Zhoulao, and damaged sinews is Shangjin. And so we can have a combination of all of those things. So like most of our the injuries we talk about, overwork, so taxation in a certain part of the body, repetitive strain, or chronic injury over and over causes damage to the sinews and network vessels of the elbow in this case. So there's not enough blood to nourish the sinews. And then you also overlay that with qi and blood stagnation that's obstructing the flow of qi and blood to those areas. So it can't get there. So insufficient qi fails to prevent external factors such as wind, cold, and or damp from entering the channel. So the door's wide open. We talked about that a little bit last week. And in comes wind, cold, damp. There's poor circulation. We can't get it out. So there's a lot of channels that are subject to this that cross the elbow, but these are the primary. So just to give you a little snapshot and refresher of where the sinew channels travel. So the small intestine I think of as the medial elbow, where large intestine would be the lateral elbow. And then Sanjiao is the posterior elbow. So this is a really cool way to treat pain. And I really just kind of brushed over this briefly last week because we didn't have time to get into it. But I want to just spend a second introducing you to this concept because this is really classic and can be really effective. So you can use the clock. And the clock is super helpful in trauma and ortho, right? Because according to our Chinese body clock, this tells us when qi and blood is flowing most freely through these channels, right? So we're not using this clock to schedule our patients. It'd be great. But, you know, between 5 and 7 a.m., I don't think anyone wants to see me at that hour for treatment on the large intestine channel for their elbow. But we can use these midday relationships to treat distally and locally in some really helpful cases to open up qi flow within the meridians. So the qi cleft points, as we know, that's where the qi and the blood of a certain channel, they pool there, right? So especially on the yin channels, they're used for bleeding disorders, but acute pain is how we use those points most often. So you use that point with the corresponding midnight point on the opposite side. So for example, let's say we've got elbow pain in the small intestine channel, so in the medial epicondyle. So we can look at this clock. Okay, here's the small intestine. So it's between 1 and 3 p.m., right? That's the injured channel. And so the qi cleft of that channel is small intestine 6. So that's down here in the wrist. You know, it's that really cool location where we put our finger right here and twist and we feel it dip in there. So we can needle the qi cleft on the affected painful side. And then you hop across to the 1 a.m., 3 a.m. side, and then you needle the luo point on that opposite side to encourage chi flow through those channels and basically just open up channel flow. So you're going to treat, in this case, it would be the liver, right? So it's the opposite side of the clock, but you use the luo point on the opposite side, which is liver 5. So don't worry about mastering this for my class, but worry about along your way knowing your acupuncture points and knowing what I call your YLAX numbers and your shoe points, and understanding the relationships between our classic points is really all you need to know. And then you can think about how to use points in this way down the line. But as long as you know your shi clefts and your luo connecting and your yang spring and your shu streams, you can come up with a lot of really effective TCM treatments. So on the flip side of that, we'll do it again real quick. Large intestine, 5 and 7 a.m., right? So the shi cleft is large intestine 7. And then we would want to do the luo to move it through the opposite side. So that would be kidney 4. So it's just an example of how to use this clock to treat pain. So you might have seen last time, like I mentioned, shi cleft points, and I threw them in there. But if we don't talk about this, or I call attention to it, it might be a little mysterious. Like, well, why would you use liver 5 for medial epicondyle pain, right? You can use the same system and the same clock to needle corresponding tissues. So you could do, like, if you were needling like the small head of the bicep along the pericardium channel, heart governor is what it's called here. You could go down to the stomach channel and, you could do the luo there, or you could go down the stomach channel and find the corresponding tissue along that same line on the other side. So like stomach 34-ish would be sort of a mirror image in a way. So we'll keep talking about this, but I'm just throwing it out there just as a way to use our beautiful, wonderful TCM classic understanding of medicine to treat pain. So rather than go through all the ailments and all the different patterns it could be, I think that's redundant, right? Because so many of the same pain patterns have similar underlying patterns. So just if you kind of understand what your differential is, you can kind of extrapolate that into various body parts. But a very common pattern in general for pain, and this does apply to the shoulder too, but chi and blood stasis with underlying blood deficiency. So like we talked about a couple minutes ago, repetitive strain and overuse causes a backup of chi and blood in that local area, right? So all those adhesions and that connective and scar tissue just kind of gets balled up, and you get a traffic jam there, right? And that's when we get Sha or cupping marks, right? When we encourage blood flow along those areas. So in that case, because it's chi and blood stag, you might have a combination of sharp and dull pain. Sharp with activity, dull during rest, often better with warmth as well, especially if there's a background of deficiency. But that we talked about latent blood stasis, right? So just like, lack of blood flow can exist in a joint or a tissue for a very long time. So that can impair circulation, and that will in turn, circulation is movement, right? So qi, that warming function of qi can't efficiently heal the tissue and warm it up. So that's kind of how you start to get these chronic cold conditions in the joints. So when the qi in the blood can't get to these places, then they're going to be deprived of nourishment. And so we need qi in blood in order to heal a tissue. So if it can't get there, you're going to be more vulnerable to re-injuring it. The sinews are not going to heal properly. They're poorly vascularized anyway, right? So you might have improper healing and just a vulnerability to continued injury or even tear. So, in all of these cases, you're going to want to do the same thing. You're going to want to move qi in blood, relax, but also kind of strengthen the sinews. And we can do that by poking a hole in them, winding the fibers together, right? And reduce pain. So classic local and the motor points we talked about in the affected tissues. So thinking about the agonists and antagonists. The Jing wells are great when there's acute inflammation. And especially when there's reduced range of motion. So in this case, in the elbow, lung 9, large intestine 1, small intestine 1, Sanjiao 1, I mean, you could prick those to bleed them and release some inflammation if it's really acute. So that could be good too for olecranon bursitis as well. And then the qi cleft on the affected channel, that alone would be great. But you could also pair that with the luo connecting point on the paired clock, right? On the contralateral side, like we just talked about. And that's really good for acute pain and blood stasis. And then classic points to support and nourish liver, blood, and benefit tendons, stomach 36, liver 3, liver 8 to build the blood, spleen 6, gallbladder 34, CV4, CV6. If you're working from behind, you'd be 17, you'd be 18, and you'd be 20. So those are all pretty intuitive, I imagine, at this point. So the other pattern we're going to see time and time again is qi and blood deficiency in the channels and collaterals with blood stasis. So it's very similar to what we just talked about. So overuse, taxation, tissue weakness, bending the paperclip back and forth and back and forth and back and forth over time, right? It weakens those tissues. In this case, you're going to have some decreased range of motion and you might actually have some muscle spasms. And the pain is going to be worse at night, usually, if qi and blood are not moving freely through the channels and collaterals. So you're going to supplement qi and nourish blood in the same ways we just talked about. You're also going to disperse blood stasis, unblock obstruction in the channels and collaterals, and alleviate pain by doing similar things we just talked about. So those are really similar patterns. Cold, damp, painful obstruction, or B pain with a potential background of kidney yang qi deficiency if the patient is over 40 or older. But again, repetitive strain is kind of the beginning of, multiple ways this can go, right? So you're just circulation somehow and leaving the elbow susceptible to pathogenic invasion and stagnation of cold and damp. So this is where we may start to get numbness and tingling and nerve entrapment, because nerve entrapment can actually be like a tethering to soft tissue, or it can be like swelling. There's just too much, there's not enough space in the tissues from like edema or swelling. So in pregnancy, that can be common too, to get some carpal tunnel, or in hypothyroid issues, you can get numbness and tingling in various places. So that's where we think about these pathogenic factors. And then, you know, if the patient's older and they just constitutionally don't have a lot of qi in blood, they're going to be more susceptible to this in general. The immune system's the wei qi is going to be a little bit weaker, and that can progress into tendon or bone B over time. So we want to disperse cold, resolve damp. Classic points to do that. We want to use moxa in this case, perhaps, as well, over these classic points or over the point, the place where it's particularly painful. So we can have the same treatment principles, but we might add a little moxa to there. So wind cold as opposed to cold damp, right? Similar. Same kind of setup, you know, chronic injury and weakness of qi and blood, leaving the door wide open for pathogenic invasions. But in wind, if there's more wind involved, then the pain might wander a little bit more and it might kind of spill and radiate to other areas. But you're going to be stiff, you know, cold can also be stiffness. And you're also going to be... the patient's going to want warmth. It's going to feel better with warmth. So ask. And we had this conversation before. A lot of times people are just quick to grab the ice. You know, don't yell at anybody, but just ask them, hey, have you tried heat? And just, you know, have that conversation. Again, with the moxa. And if there's kidney yang qi deficiency, you're going to want to treat that. Kidney 3, you could also do kidney 7. Similar thing, moxa on the points we just talked about. So it's easier, I think, to digest it in those patterns that can just kind of go either way, because you can see all of these things at the same time. So it's just good to think about all of the factors you're dealing with constitutionally and that are specific to the injury so that you can make the most thorough diagnosis possible rather than just qi and blood stasis. Okay, so here's a couple formulas for elbow pain. So this one, there's motorcycles going by. Okay, Wo Ying Zhitong Tian Jia Jian. Quicken the constructive and stop pain decoction. So you can modify this, but this is a great one for acute trauma, micro trauma, or repetitive strain. So we've got Shu Duan for weakness in the bones and sinews, and Yan Hu So is really strong at reducing pain, right? Dong Gui Wei is a strong blood mover. Zhi Shao, I think of that to reduce inflammation, right? Because it circulates blood, but it also cools it. So it's like, yeah, that's inflammation. Xuan Shang, it activates the blood, but don't forget that it also dispels wind. So that's a good one too for pain. Sumu, that's not one we talk about a whole lot, but it's really good in this case for reducing swelling. But it's in the regulate blood category and it also stops bleeding. Chen Pi, we got to address the qi as well, and we want to dry damp. So that's a good one to add, and it can also soften the blow and make it a little more digestible too. And then Tao Ren, that's a blood breaker. So there's a lot of situations where we want to break, but it's a strong blood mover, right? So there's a lot of internal situations where we might want to do that. But in this case, trauma can cause a situation where you want a blood breaker. And Wu Yao, it regulates qi and alleviates pain. And then the Ru Shang Mo Yao combo, Dui Yao, is amazing at healing tissue. It moves qi and blood, reduces swelling, relaxes and heals sinews and flesh, right? And promotes circulation, reduces pain, and then a little Gansao, of course. And then this is more like, this is excess, I kind of see this as. And then this formula, is more for like deficiency. So chronic pain, worse with exertion, better with warmth. Huang Qi, Gui Zhi, Wu Tang. So Huang Qi, we got to address the Qi. Shang Zhang scatters cold, frees the channels. Bai Xiao nourishes the blood and relaxes cramping. Gui Zhi scatters cold, frees the channels. And then Da Cao is a buddy to Huang Qi and Bai Xiao in that case to nourish Qi and blood. And then from there, you can kind of modify. Ji Shui Tang is really, really good when there's blood stasis, but the patient's also deficient. Wu Jia Pi and Wei Ling Shan are when cold damp herbs, reduce pain, and then Duzhong and Shu Duan both are really good for weakness in the bones and sinews. So just to give you a sense, I mean, there's so many possibilities, but yeah. So that is the elbow. And hopefully you feel a little less overwhelmed with the elbow in general. But let's go ahead and we have a few minutes. Does anyone have any questions at this point? And I'm just gonna mop up the end of the shoulder. And it's kind of similar to what we talked about. So there's a lot of overlap. But while I'm pulling that up, if anyone has a question, feel free to use your voice.
Jennifer, my question is more on the exam because there's just so much information. So we're going to do a 1 hour review before, and then how is the exam like conducted?
Yeah, really good question. So it's, you know, I'm not going to, let me pull up the shoulder key points, and I'm going to do the same for the head and the jaw because I didn't necessarily give you one of those because I thought of that after the fact. But I'm giving you, first and foremost, to kind of make that a little bit easier, I'm giving you a key point sheet at the end of these, right? So I would kind of summarize that for yourself. So let's go to the key points for the shoulder. I gave you that for the elbow. So, you know, I'm not going to focus on insertions and origins of muscles. I'm trying to, you know, each body part, each joint, each section we review kind of has its own set of like important anatomy. So I'm trying to give you that per joint. So muscles of the rotator cuff, if you know nothing else, we talked a lot about muscles. There's so many muscles of the shoulder. So it's spelled out here. I want you to know the muscles of the rotator cuff. What are they? The rotator cuff is not a cuff. It's not a joint. It's not a structure. There are 4 muscles, right? I want you to know them, and I want you to know what each of them does. I want you to know which one's responsible for abduction, flexion, extension. And if, so, I mean, I might give you some multiple choice question. Most of it's going to be multiple choice. So you may, or matching in a way. So, you know, match the muscle to the action. You know, could you do that? Could you recognize a rotator cuff muscle from one of the muscles in the spine, right? I hope so. So I want you to really know the actions of the rotator cuff muscles, but like in the elbow, I didn't stress the same kind of, I spelled it out there too. I want you to know which muscles are responsible for elbow flexion, elbow extension, pronation, and supination. So there's a handful of muscles that's responsible for these planes of motion. And that's the very basic level of anatomy. And I know I'm not giving you specifics about look at this page, the key points for specifics about the anatomy, and you'll find it there. And I'm not going to trick you. I'm not going to, you know, this test for those of you who were in review and assessment might be a little easier, but yeah, match the muscle to the action. What do they do? And if you saw, if I showed you, if I pulled up an image of the humerus, and I had, you know, maybe a location, could you recognize where each of the rotator cuff muscles attaches? That sits picture that I showed you. And then, you know, be able to recognize muscles of the shoulder girdle from muscles of the rotator cuff. So, you know, is the lat a rotator cuff muscle? No. Is the biceps brachii a rotator cuff muscle? No. Is the supraspinatus a rotator cuff muscle? Yes. So for questions like that, pretty straightforward. Physical exam, again, I'm trying to spell this out for you clearly. And when we meet for a review before the test, I'm gonna stop sharing this so I can actually see out there. When we do our review, I'll probably kind of throw out more hypothetical questions. You know, just so you can kind of like turn your attention to those questions. I'm not going to give you the test verbally, but, you know, based on these key points, questions are going to be drawn from that information. So if I, for example, with the elbow, I wanted you to know the difference between medial and lateral epicondylitis. So if I gave you, let's say, a case study with, you know, some information about the patient's constitution, could you, and maybe the results of an ortho test, like a positive Cosen's test and pain at the lateral epicondyle, you know, could you come up with the diagnosis from that? So ortho testing, I want you to be able to sort through and recognize which tests are for which things. Like, make sure you know that the Cosen's test is for the elbow, not the shoulder. But am I going to ask you how that's done in great detail? Extend the elbow and extend the wrist and radial, you know, deviate. No, I'm not going to do that. But if I write all that out and I say, you know, an ortho test that does this to the arm with pain in, you know, in the region of LI11, would you be able to tell that that's for lateral epicondylitis? Probably. I don't worry. There's so much information, but I don't want you to stress and worry. I pay attention to the key points, go from there. And if so, the majority of the test is going to be multiple choice or matching, you know, muscles to actions, or ortho tests to goals. Cosen's test is for lateral epicondylitis, medial epicondylitis, rotator cuff impingement, for example. You know which tests match which ailments. And if I give you a short answer, there's going to be so many correct answers for that. And this is where, you know, your sensitivity as a practitioner is going to shine, right? So if I said, you know, a 72-year-old patient comes to your office reporting pain on the lateral side of the elbow, you know, their pulse is fine, Cosen's test is positive, they've had a history of multiple injuries in the lateral elbow, what's your treatment protocol? You know, give me 5 points that you would use to needle them, or, you know, how would you treat them? You can, you can talk about gua sha, you can talk about motor points, you can talk about classic points, you can talk about herbs. I just want you to practice thinking about how you would treat a patient that walked into your office and sat in front of you. And that's going to be the most open-ended questions, but they're going to be the most forgiving. So I'm not going to have you write out how to do an ortho test, but I may have you write out how you might treat somebody. You don't need to memorize the clock, but you can remember that concept and say, I would treat the Xi cleft of the affected channel, right, with the contralateral luo point. So I know it's time to go. I can talk a little bit more about this at the beginning of class next week. So make sure you're all here on time so that you don't miss anything important. And I'm not going to stray too far from the key points I'm giving you. So I'm trying to give you a study guide as we go. So I hope that helps.
Okay, thank you.
Yeah, you're welcome. All right. Well, have a good weekend, everyone. And feel free to email me if you still are stressed out about how the test is going to go down. I know the first test with any instructor is a little stressful because you don't know my style, but it's going to be fair. I promise. So you're welcome. Thank you all. Have a great weekend.
Thank you, Jennifer.
Thank you.
Thank you.
Have a great weekend.
You too.